Well, good morning, everyone. This is Shannon Sheffett with LWI in San Diego Sports Medicine. It's wonderful to talk to you again this morning. This is just a brief conversation, a little bit about medication. Something I speak with patients regularly about is the concern of once I start a medication, I feel like it's a life sentence. That how do I know I'm ever going to be able to get off of it? I really would like to do this on my own. And so balancing that sense of autonomy for all of us, as well as the maybe need or dependence on a medication for short term or long term, is something I think doctors need to address very clearly rather than just saying, well, this is what you need and this is what's going to help you. I think helping patients understand what drives physicians to come to the conclusion that a patient needs a medication, as well as what drives the evidence-based medicine to say that this is worth the benefit. The benefits outweigh the risks for the medication. So how do we make it not feel like it's a prison sentence, but rather a bridge to cross over? One of the ways I talk to patients about medications is I say, this is, in my brain, a bridge to get you over either a very narrow or very wide ravine that I don't know how deep and I don't know how long it will be. But my hope is always to try to get you to a point where you may not need or rely on the medication. But at the same time, we're going to choose a medication that if you do need it long term, that it's not going to cause any undue harm. Or if there are risk factors we have to monitor, then I arm the patient with the knowledge of what to look for so that we can keep the dialogue open. So starting with hypertension, one of our first, I would say, if I had to pick something, one of the first things I tend to talk to young adults about is maybe elevating high blood pressure over time and how that impacts their long-term outcomes. When I tell patients that their blood pressure is borderline high for the first time, I usually will say something to the extent of, I'm worried about your 80-year-old self just as much as I'm worried about your 35 or 40-year-old self. So we start to look at lifestyle. And we look at all the different things that go into blood pressure, as well as what their blood pressure is currently and how that is defined with regards to need for treatment, et cetera. So normal blood pressure, most people are aware of, is about 120/80 or less. In many instances, people run less, and then with exercise or a stressful event, it is allowed to go above that as a normal biologic and physiologic response to stress. However, a maintained blood pressure above 120 is going to be considered elevated. So if I see somebody in the office and their blood pressure is above 120, we often will have them rest, relax, and check it again before they leave. If it remains above 120, then I give them the homework to please consider getting their own blood pressure cuff or use one at a pharmacy. To me, a little bit less reliable because it can still be a stressful environment in a pharmacy. But to get us some more outpatient or ambulatory blood pressures. Once we continue to see blood pressure, especially over 3 separate visits being above 120, it's really inherent, it's important for the physician to really open up that talk with patients. Hypertension in stage 1 is diagnosed as anything above 130 or in the 80s to high 80s. But once you hit stage 2, that's over 140, over 90. Now, the top number is your systolic blood pressure. That's the pressure of the heart to deliver the blood to the rest of the body. And your diastolic, the lower number, is a passive pressure. It's the filling pressure of the heart. So if you think of the heart as a balloon, over time, if the compliance of the wall of the balloon is increasing, it's going to be harder to fill. And therefore, that bottom number will start to raise. So as physicians, we look at systolic hypertension and diastolic hypertension as 2 different entities, many times seen together, but the diastolic hypertension is not as sensitive to lifestyle measures. So I always like to clarify that as well. So how do we look at your risk factors to help patients understand whether or not this blood pressure should be treated? This is some data I took just from one of the American College of Cardiology and American Heart Association task force papers. That in about 2018 is when this one was released. And it just showed some statistics about 93% of an average adult over 45 have a 40-year risk of developing hypertension. So 93% for African Americans, 92 for Hispanics, 86 for whites, and 84 for Chinese. So with this, their statistics, but I use sometimes statistics to help patients understand that as we age, we all have a risk, no matter our ethnicity, but our ethnicity plays a role. So we always want that family history. We want patients to kind of look at the genetic risk factors or the nature versus nurture discussion. In 2010, hypertension was the leading cause of death and disability if you adjusted for worldwide. And in people over 30, if we see higher blood pressures, as a physician, we're looking at the ticker tape of these following things, which I can explain what they mean. Increased risk for the CVD is cardiovascular disease. So as your blood pressure is higher, it increases the pressure on those blood vessels, therefore makes them over time less compliant, which will elevate blood pressure more. Obviously, if there's atherosclerosis or cholesterol and other comorbid conditions, this is going to be even more worrisome. And diabetes, we're going to touch on in a minute. Angina is chest pain. So of course, if somebody does have coronary artery disease or cardiovascular disease, they may have more chest pain-like symptoms when the blood pressure is uncontrolled. Myocardial infarction or heart attack is, of course, if somebody's blood pressure is uncontrolled, they are obviously at higher risk for an event such as that. Heart failure is a term, of course, there's a couple different types of heart failure, but as a general statement, if you have elevated uncontrolled blood pressure for years at a time, you are running the risk of the heart developing either decreased compliance and diastolic heart failure, or too much pressure on the system and becoming a more systolic heart failure where it can't pump out the percentage of blood that we expect it to. Hypertensive stroke is a condition in which the blood pressure raises so dramatically that it actually causes a blood vessel to leak or rupture in the brain. So obviously that would be more concerning for high blood pressure or labile erratic blood pressure, but still is a long-term risk for even low-level blood pressures over time, going back again to the cardiovascular disease, setting people up for that. Peripheral arterial disease is, this is where people can get pain in their legs when they're walking. It has to do with the delivery of blood to the legs when the muscles are demanding more oxygen with walking and exercise. So as people develop peripheral arterial disease, which is highly linked to high cholesterol, but also blood pressure plays a role in this as well. Abdominal aortic aneurysm, this is often found with a genetic link, but can occur in and of itself in adults. We do screen people for this here at LWI with your physicals, but with the abdominal aortic aneurysm, if you have a labile or high blood pressure, you do run the risk of causing this aneurysm to become weaker and weaker and potentially rupture. Just things to think about when we look at the risks of hypertension and compare it to the risks of medication. Non-pharmacological treatments always going to be the first thing we talk about with our patients here, but in any office, I guarantee physicians are doing the same. We're going to look at the weight. We're going to look at things to help them understand that the higher the weight, the more pressure on the blood vessels, the more likelihood of high blood pressure to deliver the blood. The heart has to work a little harder to deliver that blood to the rest of the body. Sodium restriction, most people are aware that sodium in your diet can increase blood pressure. Some people are much more sensitive to this than others, so we do this on a case-by-case basis, but we do find that that's something that can be a non-pharmacologic treatment. Potassium supplementation is just kind of making sure that you have enough ample potassium in your diet, you don't get low. Increasing your physical activity is kind of part of the weight loss blood pressure discussion. Pretty much every doctor I know is going to tell you if you become more physically active, it will benefit your blood pressure. And limiting alcohol. This is a tough one, especially during quarantine, I hear. But limiting alcohol is something that can be sneaky. So if with men, it can be a maximum of 2 drinks per day, and for women, 1 drink per day. That can cause elevation in blood pressure in some, again, case-by-case basis. But in general, most doctors are going to recommend you keeping your alcohol under this amount, not just for blood pressure, but for other reasons with the liver, etc. But just something to know. So how do we as doctors look at this? This is a table that pretty much exists in our brain. We don't have to look at this to know whether or not a patient needs blood pressure, but there is a percentile risk that we can assess for patients, and I do like to give my patients this information when it's adequate, of what is their risk in the next 10 years of heart disease. So primary prevention is when you have a patient that has just now had 3 or 4 high blood pressures, or they're saying their home blood pressure is high, and you want to strategize whether or not they need treatment. The middle bar there, this is primary prevention. If you have, this is going to be a patient that doesn't have the known history of heart disease, so that's why there's no in that first column. The second column is their risk seems to be a bit higher on the cardiovascular risk assessment. And what this is saying is that, and I'm going to come up in the next slide to show you what that risk assessment looks like, and you can go online and do this yourself to see what your risk is. And we look to see if there is higher than 10% risk in the next 10 years. And then if their blood pressure is running over 130/80, then I would recommend treatment. But even if you have, so the bottom row there is less than 10% risk of an event in the next 10 years, is if your blood pressure is over 140/90, you really should be on blood pressure medication, despite the risk being less than 10%. Basically, we're saying we don't want you to get to that point because your blood pressure is already high and the road is heading in that direction. Secondary prevention is when we already know somebody is at risk. So say this is a person with a history of stroke, heart attack, peripheral vascular disease of the legs, and we're going to probably tell them anyways that they need treatment of their blood pressure, but it helps to have the patient understand at what level. With them, even if they're 130/80, I'm going to recommend to bring that blood pressure down below the 120/80. And then at that point, once you've had these risks in your past, you're already a known greater than 10% risk of a next event. So to summarize, basically anyone who's had a heart attack and has a blood pressure of 130/80 is going to recommend treatment. Very strong recommendations. That being said, if you've had a history of heart attack, stroke, or vascular disease, most cardiologists are going to want you on blood pressure medication, even if you haven't reached 130/80. And those are seen in case-by-case basis with risks and benefits assessed. If you're considered to be high risk for heart disease, i.e. family history, smoking, and your blood pressure is 130/80, we're going to want you on it. If you have no risk whatsoever, but your blood pressure is consistently over 140, we're going to need to have that conversation to at least talk to you about it if we cannot control it with lifestyle measures. Moving on to cholesterol. This is a big one that we talk about. It's a hot debate. Everybody knows about the statins. And just so you know, I'm not going in and breaking down the different types of treatments because that's really a case-by-case basis. But for cholesterol, this is a big one too because it plays such a deep role with high blood pressure. There is a lot of genetic and familial risk factors involved, as well as diet and lifestyle. So what it takes is really getting to know your patient and getting to know where the different sources of risk are coming from. So quick summary, we all know our good versus bad. Some people, I call it the helper versus the loser. But there's many different terms that we doctors will use to jokingly get people to help us understand. And for your HDL or your good cholesterol, this is going to carry excess cholesterol from your diet into your blood back to the liver to help be broken down. Whereas the LDL cholesterol is going to carry that cholesterol from your diet into the bloodstream. And if there's too much, it just needs to start to deposit itself into the arteries, causing narrowing. So what we're looking for here, and then triglycerides are actually an excess of calories needing to be stored. So the body has this increase in energy intake from calories and needs to store it thinking I'll use it later. But unfortunately, many of us don't use it later because we move on to the next meal. So triglycerides are real tricky when I talk to patients about it. We have specific handouts that we can give you if your triglycerides are high. And triglycerides are their own risk in and of themselves. And how we calculate the total cholesterol is just the equation I put down here at the bottom. So how do we treat the high cholesterol? Going back again to lifestyle factors, your low-fat diet, regular exercise, limiting the alcohol, all sounds kind of the same as with blood pressure. I didn't really mention smoking with blood pressure, but that's also definitely a factor in smoking cessation. There are others as well, but these are kind of the main things that we're going to talk about first. So when you get to the point that you have been trying all the lifestyle measures, but your numbers are still high, then you need to start breaking down the risks and benefits of the different types of medications. We have supplements, which I know we talk to our patients about, omega-3 fatty acids. There's red rice yeast. There's many different supplements that have been touted and have good evidence-based medicine to say that they're a good segue prior to starting statins. But there are just some cases where you have high risk behind you, either family history of heart disease, family history of stroke, family history of peripheral vascular disease, or you yourself are developing symptoms of any of those, that the statins are really going to help with your long-term goals for disease management and prevention. So this is where we have to really talk about those benefits. And then with patients, I really like to break down what their fear is of the statin, absolutely help them understand that we too look for things like the muscle aches, the pains. We also are monitoring for all the long-term outcome studies from statin therapy. But there's a lot of data to show that statins do help decrease the risk of cardiovascular events. And for us doctors, again, we're looking at your 80-year-old self, not just at your 45 or 50-year-old self. And so when we get to this conversation, this open dialogue is very important. Basically, the way I like to look at it is I'm a consultant, and I'm just going to provide you the most up-to-date information I can to allow you to make a choice for your long-term goals. So once we consider the medications, this is kind of what I was referring to earlier with the blood pressures. We use this calculator. It's called the ASCVD calculator, or atherosclerosis cardiovascular disease calculator. You can find this online with the American College of Cardiology. And the beauty of this one is when I estimate the risk, it actually, and you can't see it on this slide, it'll do a therapy impact and advice. It'll pop up with all the data and information to help patients understand where these recommendations are coming from. What's interesting is, especially back in training, when we looked at heart disease risk, we often always included family history, which isn't included in this. But there is that additional factor that we need to also put in there. But this one is a very good way to break down what we're looking at. So I kind of did here how you see the estimated risk and what it points out as. It helps you understand the estimated risk. There are apps for this. It has even apps to help you with lifestyle management. And then it really breaks down how we look at that 10% risk, as I mentioned before, and what kind of things we're looking at. So if you're more than welcome to take a look at this, this is something that we use when we're assessing labs every quarter, every year. So moving on to diabetes. This one is actually, I'm going to be focusing more on pre-diabetes because we all know once you hit that diabetic range that the risk is pretty significant. In fact, for doctors, we consider diabetes as a coronary artery disease equivalent, meaning if I have a diabetic, I have to look at them the same way for heart disease risk as I would somebody who's already had a heart attack, because we know the statistics are so. So what I was basically saying is prediabetes is more prevalent than we know, and that's because many insurances don't let us run that hemoglobin A1C, which is an indicator of blood sugar over 3 months period. When I run that, I get a really good idea on if somebody, as you can see on this, the right side of the screen, is there's the arrow, and this A1C, if they're around 5, I'm not as worried, but if they're getting between 5.7 to 6.4, I have the ability to tell them that they're at higher risk, as opposed to waiting for the fasting blood sugar to get significantly high in order for the insurance to allow us to run an A1C. So this is something that we're trying to be able to advocate to order more as a preventive assessment for patients to give them more knowledge of their risks. It's estimated about 86 million Americans have prediabetes, or 9 out of 10 don't even realize they have it. So this is pretty significant, and it's something I'm real passionate about, trying to help people understand well before they have to worry about medications. But once we have prediabetes, it's important, if lifestyle measures aren't improving them, to help the patient understand to keep coming back and talking to their provider about other options, because there are options to treat that prediabetes now with medications. It's just not, of course, the first thing we're going to offer or recommend. So again, lifestyle modifications, this is American Associate of Endocrinologists, can be difficult to maintain. As we well know, diets, especially the American diet, can be very challenging to stay away from. the simple sugars, the white flours that have been known to have an increased glycemic index or effect when you eat them. Uh, Basically, we're going to focus on a realistic stepwise goal. Obviously, that's working with Linda, it's working with Megan, and having that nutritional plan and avoiding those high glycemic foods. But cognitive strategies are important as well as we're coming up with different pre-diabetic treatment plans for lifestyle, is looking at the hurdles. So I do a lot of discussion about when a patient is eating, what time of day, if their stress eating is a component, and what kind of social support they have as they're looking for dietary changes. One of it is if the whole family is eating chips and there's a single person in the family that has a trouble, or we're really trying to avoid medications or trying to make some really aggressive changes, I'll ask the family to maybe do those as treats outside of the home. It's better for them in the long run, but to not have that kind of readily accessible junk food and sodas may assist in helping us decrease access to some of those foods. And just reinforcement and encouragement. We're a team, we're all human. I would say don't look back, we're not going that way. And that each day is a new day to try different measures and things that we can focus on, especially right now during this quarantine. It's been a lot of discussion about helping people stay active, and the food is just so readily accessible if they're home. So we're just working on those kinds of strategies. With prediabetes, it may be hard to read this, and I think Linda will make these slides available so you can look at them. But what this is looking at is intensive lifestyle intervention, which is basically what we just talked about, versus metformin versus placebo. So metformin is a well-known diabetes medication. It has one of the lower risk side profile effects. It does have GI side effects, which some people have, but it does usually improve over time. And metformin helps us just make the liver a little bit more involved in the processing of sugars, just a really quick way to talk about it. And with this medication, it also does have the benefit of weight loss for some. So it has been found to help us with some of the insulin resistance that can be seen when you have prediabetes. So, because there's definitely many factors involved. So as you're looking here, especially towards the side, you can look at the change in risk of diabetes. The first one is based on age, and the white is a 25 to 44-year-old. The gray is a 45 to 59-year-old, and the black is greater than 60. So the first column on the first upper table is showing, or graph is showing the intense lifestyle interventions versus placebo. So you had the greatest change in the 60-year-olds, and less of a change in the younger adult. In the metformin group, though, you had a greater change in the younger adults. And then as you come down, I like to show in the body mass index, with a higher body mass index, you're seeing a percent change in the positive. It's a little hard to read these, on the ILI versus metformin one, as opposed to in the other one. So basically what they're saying is that in each of these groups, if you compare, you have to break it down into age, body mass index, as well as the fasting plasma glucose in order to understand the difference in change. But we do see that metformin can cause percent change in the decrease in the risk of diabetes in certain groups, especially if we compare it to placebo. But you need both of them really to see the benefit. You need the intensive lifestyle intervention as well as the metformin. So I'm never an advocate of just a medication. It definitely involves the lifestyle changes as well. So those are really brief. I apologize that the Zoom wasn't working very well for us today, but basically it's a really brief discussion that please see medications as a bridge. If you end up needing to be on them, our hope is, of course, to always find ways to get people off of the medications. But at the same time, the development of these medications has improved our life expectancy, longevity, and quality. So there's some benefits. I'm now going to click off my screen, get back onto the Zoom with you, and see if you have any questions for me.
Question for you.
Hi, Scott. How are you?
I'm good. I'm listening in. Not necessarily blood pressure related, but more or less cholesterol related. I'm 41 years old, and I've had a couple checks the last year or so, and there's been some things that have been in the red columns for me, and and doc has, made the suggestion that maybe I go on to some sort of cholesterol type medicine as it has run in my family. But it hasn't been something that I have done yet, just because I just haven't done it. I went to my docs at the military base, and they looked at my chart, and they tend to say that they would start me more at a 45 or 46-year-old age, just based on my activities and the things that I do. So just your thoughts on cholesterol while I have a question about it.
Yeah, it's really, so this is probably the harder age group, because that ASCVD risk profile, it's really more geared towards 45 and up. And I have a real big hard time too. Once you're 70, it also doesn't really let me assess. So I think that those age groups that run outside of the main data are a little bit gray. That's when I start to kind of factor in family history and lifestyle. Obviously, somebody who's going to have a more active lifestyle and is doing, as much, if their job obviously includes a great deal of physical activity, if they're mitigating and decreasing alcohol, tobacco use, anything else, then we can monitor. Once you reach a certain point, though, there is definitely a risk for vasculopathy to be developing even in a healthy adult. We've seen marathon runners, things like that, have silent development of conditions, which is what we're trying to avoid. So I'd have to really look at the numbers and look at the trends and see if they're consistently high and getting significantly higher in the low density lipoprotein or the ApoB, which we do a more in-depth lipid panel. Then we're going to probably start to at least say, hey, in the pre-contemplative stage of treatment, and if it keeps continuing to increase despite all of the healthy factors in the life, then we may want to look at that. I'd have to actually look at the numbers and the trend more than anything. That's the beauty of having quarterly or annual labs, is we can really look at the projection over time.
No, that makes sense. I appreciate it, but just was looking for your thoughts on it. It's just something that's always in the back of my mind.
No, and I try to be conservative. My nature is a little bit more of a minimalist by nature when it comes to medicine, but at the same time, I feel very responsible for the future, in the sense that we don't want to ever look back and say, darn it, we really should have put him on a statin. So we have to use the evidence that we have and then look at the trends over time and then make it as a team, because the patient really is the one that has to deal with the medication and the follow-up and all that. And it's just a team decision for sure.
Check. Thanks. It was good brief. Not my question had anything to do with the brief, but it was a good brief.
That was good. It was very good. Well, I hope you have a great day.